Hello everyone, this is Shadris and this is SIF 2022. With me is Chintan Patel. He is an interventional cardiologist at Real Health. Chintan, this is your first time with us in the studio, but this is your multiple time at SIF.
That's right. In fact, SIF is the reason I moved out here to Arizona. I loved my time on the East Coast, but you don't have to shovel sunshine. That's why you come out here. But thank you for having me.
Absolutely, yeah, thank you. So one of the topics that we did not cover yet is PE, or what's called the PERT program.
Sure.
So a couple of talks was yesterday, but really we want to dive deep to see how are the challenges to build a PERT program and how you started.
Well, thank you for asking. I mean, me personally, I'm a bread and butter coronary interventionalist. Expanding out to the PE world was actually something that happened at my local hospital in Tucson out of chance with the trauma service. Our first patient ever was a young gentleman with a liver laceration, recent surgery, ended up developing a PE with VT, and we ended up having to do something for him that could not involve TPA. And fortunately, getting in touch with the Inari reps, we were able to get some stock where we could go and do the case right then and there. So I learned on the job, really. From that, we recognized, especially in the COVID era, that PE, especially submassive PE, is grossly undertreated in this country. Mm-hmm. It's difficult to treat, but it's not impossible. And what we learned at our center, which did not have surgery backup, a very small community hospital, was that we could do it with the right patient selection.
Yeah. So when you say selection, you have to set up a program, right? Whether the ER on board, ICU, cardiologist, IR sometimes. So how did you start, and what's your tips and tricks?
So anybody that wants to start a program has to understand that it goes first with identification, obviously. So you have to get buy-in from the ER and the hospitalist and the ICU staff. Right. Understand that they need to know what the methods are involved, what are the medications that are going to be involved, what is the recovery going to be like, an education at that base level. Right. And that helps in working with radiology and interventional radiologists to identify those patients and really decide as a multidisciplinary team, are they a good candidate? Right. Certainly, being in a larger center with surgical backup obviously helps, and getting a buy-in from a CT surgeon is going to always be a great thing, especially when you're dealing with that space.
Yes.
But the pulmonary arteries are tricky in the sense that there's very little that can be rescued if something bad happens. So IR especially can be very beneficial in that space as well. But what we did was we went to the ER, we made sure that they had our contact information, we told them the kind of patients we were selecting, what are some of the laboratory things that we want in addition to something like a D-dimer, troponins, BNP, what are we looking for, stat echo, what are we looking for in CT measurements, and training our radiologists as well. I would say the overwhelming majority of radiologists are prepared to comment on things, but what we learned from them was how to interpret it ourselves, so that if we had to independently review a study at home before the prelim read was there, we could comment quicker. Right. And it helped to dramatically decrease the hospital length of stay, improve patient satisfaction, improve patient morbidity. Yeah. Obviously, that space is still ripe for mortality data. We're just getting into this in its infancy, in my opinion.
And as you said, it's almost like a STEMI call, different STEMI schedule.
That's 100% true.
But how did you get the buy-in from other cardiologists in your center?
So where I was before, we had a very small cardiology group. The hospital was about 300 to 400 beds at most. The trauma center was a brand new program. And we were one of three I was one of three interventionalists there. So we had immediate buy-in because there was no other service like this offered. Yes. And so the fact that we could do this, and really the main thing that helped to really convince hospital administration, convince the hospital staff, was we were keeping these people out of the ICU. Mm-hmm. And in the time of COVID, that was instrumental. That if I could do an Inari or a penumbra procedure and not, I love the ECOS technology, but the problem with our current protocols is that they still have to go to the ICU. Yes. For close monitoring. Which is very difficult. Our workflow got to a point where they would go from the ER to the cath lab, aspirate, get their vital signs to a much more stable condition, and either go to a step-down unit or really even an observation unit at that point. And again, that comes with some good patient selection, good technique, really trying to make sure that we're keeping an eye. We have to have a lot of buy-in and investment in monitoring the patient post-op as well.
Right. Is it a steep learning curve from interventional cardiologists to learn the technology we have for PE, or is it more shallow?
Personally, I think it's shallow, and that's not a commentary on my technique. I think if you're open to advice from peripheral interventionalists, vascular, interventional radiology, they have a lot of tools, but truth be told, we spend the most amount of time in the pulmonary artery space with just simple right heart catheterizations. So understanding our level of comfort of what our equipment can be used there and kind of expanding that. I personally think that we're best equipped for this.
Yes.
But truth be told, because of all the other institutionalized experience that the other interventional radiology and vascular has, they're a huge valuable resource.
Do you think there should be a proctorship program for physician, or this is something one-time stop?
No, I think a proctorship is a great idea, to be perfectly honest, because every PE case is so different. The hemodynamics of the right side of the heart are just so variable. You can have, and to some extent they mimic the left side for delayed care, but what we forget a lot of the times is the right ventricle, in addition to getting a traditional coronary supply, gets a lot of its blood supply from intrinsic blood flow there. So when you start to inhibit that, and you start to put strain on a much more delicate structure, the changes in hemodynamics very rapidly have to be accounted for. And that's where I think a proctorship, as we do more, we're all learning, just like in the coronary world.
Correct.
When stents started coming out, we learned through experience, and I think we're now at a point where a proctorship may be appropriate.
And maybe, as you said, it's a public health issue down the line where preventing some pulmonary hypertension cases
absolutely.
from happening.
Absolutely. Right now, I mean, critics will say that, there is no mortality data, and I can't argue with that. But I think we're getting better, much like with PCI, much like with peripheral interventions. We know that mortality is absolutely important.
Yes.
But morbidity should matter. And how people are, I've seen patients who have not been able to come to my center, get traditional therapy for PE, and now subsequently live on oxygen forever.
Yes.
And these are highly functional people, and it's not fair to them.
Yeah. So we are interventional cardiologists. We evolved from clot busters to clot suckers.
That's right. That's absolutely right. I always like to say we're just fancy plumbers in one way or the other.
Well, thank you so much, Dr. Patel, for your time.
Thank you for having me.
Giving us an insight about Perth. This is an evolving field for all the viewers as well, the fellows. I mean, this is something they should get hand-on
100%.
during your training, because it's going to be coming your alley right away. Again, thanks for your time. Please watch this video and others on SIF YouTube channel. This is Shadi Reyes from Detroit Medical Center. Thanks, Dr. Patel.
Thank you.